All right, well, welcome back, everybody. Hope you had a moment to stretch. I was impressed with how many people that could actually pull off the tree pose in the audience. Also hope you had a moment to visit with our exhibitors out there. We're really fortunate to have such a great group of industry partners who not only are helping support the event financially, but also really are engaged with the patient journey. I think all of those that we've worked with are very hungry to kind of learn more about the process of head and neck cancer treatment, navigating survivorship, and how they can best support those who come to them for care. So really encourage you to spend a moment during any breaks to go by and say hi to them, introduce yourself, and tell them a little bit about kind of your experience. So our next session is Mouth Matters, Essential Dental Care Before, During, and After Head and Neck Cancer Treatment. It's led by a good friend, Dr. Joel Epstein. Dr. Epstein is a diplomat of the American Board of Oral Medicine and has appointments both at the City of Hope here in Los Angeles as well as Cedars-Sinai. Please join me in welcoming Dr. Epstein and his panel. Thank you.
I could almost use the step stool, but not quite. Thank you, Mike, and thanks to the organizing committee. The Head and Neck Cancer Alliance is an amazing group that's starting to develop this communication venue and structure, and we have, as mentioned, several hundred people here and then online presence. So we will try to pay attention to the online people as well by alternating questions during the session. So what I thought I would do is usually I begin with a mouth talk in a sort of it doesn't matter which audience actually, to say that medicine and dentistry have successfully extracted the mouth from the rest of the body. That's a bit of a dental joke. But now we're bringing it back, and I think probably the majority, maybe everyone in this room understands the interaction and the part of the body that the mouth represents. And part of the issues that we all have is these are siloed communities of education, research also, and clinical care, and we really need that integration of the team concept with respect to oral care in the cancer setting. So I'm going to try and emphasize that. So let me go to the next slide, if I can. Yeah. Okay, so one of the, just some general comments that I added as an introduction is cancer we used to think of as a cure. We also think of it now as a chronic disease and potentially with maintenance therapy. And that's a change in the paradigm from cure only and, in essence, palliation to supportive care throughout the continuum. In the oral care world, in the Mouth Matters talk, emphasis is on dental and oral care from the beginning, in fact, early detection and diagnosis, and maybe prevention of cancer down the road, and beginning currently, and then assessment and pre-treatment to reduce risks during acute phase of therapy and long-term. So the oral care issues are a continuum, and they're a part of the whole pathway that everybody may experience, from diagnosis to treatment to survivorship. Again, the mouth is a part of the body, and we often, because of this siloing of education and care, we often see underreporting to providers on the medical side about the dental issues and on the dental side about the medical issues. And if it's underreported, if you don't tell us, we don't necessarily assess it. So underreporting leads to underevaluation, underdiagnosis, maybe undertreatment or inappropriate treatment. So the dental role is from start to finish, from the beginning throughout survivorship, and we hope to develop teams that will be better at addressing that. Integrated teams are the best for care. It allows better communication, more integrated management, and this doesn't just include dental and medicine. It includes, like individuals in the discussion earlier, dietary, speech therapy, physical therapy, emotional support, and general medical needs. So we're going to try and address through this short session mouth matters related to head and neck cancer throughout the cancer journey. And one other thing that I was asked to comment on and my name was either fortunately or unfortunately mentioned during the end of the last session, is red and infrared light therapy or photobiomodulation therapy is one of the additional modalities that has been shown to affect acute care needs in head and neck cancer, specifically mucositis, but also reduction and improvement in neuropathic pain and tissue fibrosis. It's developing research. It's an adjunct to therapy. There are other modalities that are being addressed, but this is something that we offer to some of the patients that are willing to attend to have those therapies provided. So that's just a comment on the session before. So basically, I'm thrilled to be introducing the team that we have for a presentation today. Our first speaker is Jamie, who's a cancer survivor from the area, will tell us about her experience throughout the course. And at this time, we have two experts from LA area. Dr. Eric Sung is professor of clinical dentistry in special care at UCLA, focusing with a lot of patients in head and neck cancer. And Dr. Andrew Larson is head and neck oncology surgery at Kaiser in Los Angeles, and they will present a dental view and a surgical view, and then we will have the time for questions and discussion as at the earlier session. So thank you, and I will introduce Jamie.
Hi, can you hear me? Okay. I've been on many stages, but this one is probably the most important one yet. I'm Jamie, and I'm a tongue cancer survivor. But before I added that accolade to my resume, I was a performer, I was healthy, and I was hopeful. That sounds like such a downer of an opening, but it's important to acknowledge the hope and the person I was before this doom, because that's what it was. The person that I was before the cancer, before the anointed brand survivor, okay? Do we all remember the person we were in December of 2019? I remember one morning in particular, I woke up, I felt a bump on the left side of my tongue. That's so weird. Did I bite it in my sleep? Oh well, it'll heal on its own. Time for my workout, time to tackle the 235 items on my to-do list and teach my kids how to read. Don't have time to worry about it. Christmas passed, and the excitement of a fresh all-star year was ahead of us. 2020, this is going to be our year. Woo! Well, I had a dental cleaning already on the books. So at the appointment, I asked my dentist about this pesky bump on the side of my tongue that wasn't healing, despite my knowledge of knowing that the tongue heals very quickly. And he simply replied, nah, I won't worry about it. Went on cleaning my teeth, sent me on my way. Well, I was worried. Was it just my paranoia, or was this bump getting bigger? Surely it wasn't rubbing against my teeth a week ago. I panicked, I went to urgent care, and they immediately panicked and then sent me to an ENT. Well, that included hurry up and wait, so I had to wait a whole month before getting seen by an ENT, who a month later told me, whoa, wait, you have tongue cancer. You can get cancer where? What? I don't smoke, I rarely drink. How did this happen to me? I'm very healthy. I was angry for a really long time after that diagnosis. I wanted answers. I'm a problem solver, and nobody could give me any answers. This shouldn't have happened. I did everything right. This shouldn't have happened. So, March 2020, a banger of a time, okay? I had my tongue cancer surgery. I was alone in the hospital. No visitors allowed due to COVID. I felt like Tom Hanks in the movie Castaway. Instead of a volleyball named Wilson, my companion was the call button that slowly started to have a personality. I had to get out of here. Feeling like a Frankenstein with my tongue made from my legs, feeding tubes coming out of my neck. They sent me home and I was placed on hospice because they needed beds for COVID patients. Healing at home, I knew my fight wasn't over. I needed 30 rounds of radiation. So before radiation would begin, I would need all my wisdom teeth removed to prevent my jaw from breaking during treatment. I laughed when they told me this until I realized they were serious. I just had my tongue cut out 2 weeks ago, and now you want to take my wisdom teeth? Where's my good old call button companion when I needed them? I thought surgery would be the hardest part. I was very wrong. Radiation was the most brutal thing I have ever endured. My neck burnt, blisters all in my mouth, water tasted like sewage. That was really hard. And the speech progress I had worked so hard began to slip away. For weeks, I couldn't even brush my teeth. Toothpaste, even children's, felt like fire, so I wrapped gauze around my finger and I wiped my teeth one by one. I felt like I was constantly on defense, just trying to get through the next hour, the next day. Radiation left me with lifelong side effects that shaped my daily life. I know the radiation side effects were rattled off to me before treatment, but it was also followed with the words, "This will give you the best chance." And that was all I needed to hear. I was doing it to survive for my kids. My kids don't remember what I sounded like before, but I do. My kids don't remember what I was like before cancer, but I do. What I can't remember is the last time I slept through the night. Radiation left me with dry mouth that wakes me up every hour. I spray my mouth down like I'm watering a houseplant every night. Every morning my alarm goes off at 4:30 a.m., not for a workout and not for quiet time, but so I can physically pry my mouth open with my hands because radiation has left my mobility so rigid. I have to take breaks from talking. Who does that? Okay, I know a couple people who should do that. I don't enjoy food, but I can remember what food used to taste like, and I can feast on that memory. My confidence has wavered from this cancer. I was embarrassed for such a long time about my mouth and how I sounded. I feel like head and neck cancer is something that is hard to get your mind off of because you can see it, you can hear it. The pain is always there when I talk, when I eat, when I smile. I smile a lot. Not because the path has been easy, but because I'm proud of the resilient woman I've become. I stand here today unshielded and honest as both a patient and a mother and as someone who believes deeply in the power of being heard. Sharing my story isn't just personal, it's purposeful. It's about helping others navigate what for many feels like an overwhelming and isolating time. It's about advocating for change in the systems that serve us. I am hopeful for a future where treatment plans are not only medically sound, but also patient-centered, where self-advocacy is welcome and collaboration is standard. Because the truth is, small actions can create a lasting impact. Listening is powerful, empathy is essential, and every patient voice, including mine, holds meaning. Thank you.
Hi, my name is Eric Sung. I'm a dentist, and I'm at UCLA. I think Jamie's story is just something I get to hear, unfortunately, all too frequent. So, I'm just going to go over a little bit about from a dental perspective, or I know, and Dr. Epstein mentioned it. It's so important, the integration of dentistry and medicine, and throughout the whole career, it's a separation, and bringing it back is so important to be together, and part of understanding that. So I'll go over a little bit. So today, again, educating patients and caregivers on oral health practices, potential complications, and importance of regular dental care. I mean, that's true for all, but this is especially true for oral cancer survivors, and I'll go over that briefly. And one thing that I do want to mention that now treatment has evolved quite a bit over the past, during my career. And some of the complications that we see associated with head and neck cancer doesn't affect everyone. Everyone is different because although the head and neck is such a small region, the treatment itself is highly variable, and the side effects, the complications, may be very different between individuals too. And just looking at head and neck cancer itself, the effects is highly variable. I mean, it's not just the old, young, it's everyone. So when I talk to dentists, that's one of the things that I really emphasize, that you can't just assume, in that situation, you're young. There's no risk factors. There should be nothing going on. You have to be very vigilant on what you do in your head and neck exams and things like that. So pushing, again, for the dentist or for whoever to make sure they follow up. It's so important. So briefly, we talked about getting your wisdom teeth removed prior to the start of radiation. I mean, there was a purpose for that because we need to really look at the long term. Any infected teeth, anything with poor long-term prognosis, we really want to remove those sources prior to the start. And so that's where all the treatment was prior to the start, and setting people up so they know that you need to brush properly, and it's a lifelong caring for your teeth because the complications can be so high. Of course, during radiation, as Jamie already mentioned, it was sore. The head and neck radiation, you get that burn in the mouth. There are ways nowadays, as advances continue to occur, there are ways to reduce that. But as you recall, 6 to 8 weeks, it's just really sore, and it's hard to consume foods, even liquids. Forget about brushing. I mean, all our toothpaste have this minty fresh. Everyone says it's got to be minty fresh, but that sure burns. And so it makes it very challenging. So my focus really is going to be after radiation. And it. So the main ones, again, Jamie's very eloquently described. There's 3 things. You get dry mouth. You can get cavities really easy. And then trismus too, the ability to open the mouth. And I'll go over that briefly. So the key really it depends on where the radiation is. You have some major salivary glands here. And if that was in the field of radiation, your mouth will be dry. Now, dryness also is one of those things that's a moving target to a certain degree. As you age, if you're taking more medications, the mouth will be drier too. Combined with radiation, your mouth can be extremely dry, where sleeping through the night can be really, really challenging. Now, one of the side effects is when your mouth is super dry, it's hard to keep it clean too. The bacteria, the plaque really sticks to the teeth. Okay, so in those situations, you could get cavities really, really severe. So you can see in the pictures there, hate to show these wonderful pictures, but the cavities is in classic locations at the gum line and on the incisal edge where it bites. So if your mouth is really dry, you really need to protect it with higher fluorides. And your dentist, we make these trays to help you protect it. There are also special toothpaste that has higher concentration of fluoride, which will again decrease your cavity risk. So those of you who are getting some cavities, make sure you talk to your dentist about getting the prescription strength fluoride. And if you still continue to get cavities, get the trays, the custom mouth guards where, those of us with children or grandkids, we all had that fluoride where you go visit a dentist, they bite down. So we make these custom ones so you could do it daily. It really does help reduce the risk of cavities. You also, with dry mouth, you can get yeast infections at a much higher rate. And the last but not least is the trismus, the inability to open. So there are treatments again, but the best one in literature seems to suggest as soon as your mouth gets tight, especially when you have radiation in the areas of the jaw muscles, as soon as it gets tight, start stretching it out, and we can preserve that. Once it gets really tight, it's actually hard to go backwards. After radiation again, so there are complications associated with that. And this is where it's kind of really the customized care. You need to know where the radiation is focused on. The picture on the right, that's something that I would like to see, so I know exactly what area of the mouth was hit with the dose of radiation, because once it hits a certain dose, then the complications, the rate of it increases. So if you've had head and neck radiation, the dentist or the surgeon, meaning the dental team, really need to look that information up so they know what's your risk factor, because one of the greatest risk factor is osteoradionecrosis, where the dose of radiation reaches a critical point where you can no longer heal. So if it reaches that critical point, you really can't have dental surgery, and that means gum surgery, extractions, and even there's a root canal surgeries. And so this risk is actually lifelong. So don't ever forget that, because a lot of people goes, oh, you're cured. It's been years. You're fine. That's actually not the case. The risk will actually increase with time. So make sure they look that information up. And it's also customized to you, okay, because it depends on where the radiation was and where the tumor was. And that's all I have for today. Thank you.
All right, good morning. My name is Andrew Larson. I'm a head and neck oncologic and reconstructive surgeon here at Los Angeles at Kaiser Permanente, and have the privilege of taking care of our head and neck cancer patients in Southern California. And I'm going to start by saying I am not a dentist. I don't have formal dental training, but as a head and neck cancer surgeon, I'm talking about teeth all the time. It's an issue that I talk about with patients before surgery, thinking about during surgery, and constantly talking with them about after surgery during their surveillance process in their journey with head and neck cancer. Sorry. So every patient that I meet preoperatively, talking about who will be having surgery for their head and neck cancer, comes in with a little different perspective. Some of my patients have oral cavity cancers surrounding or involving teeth, and the dental journey for that patient is very different than an edentulous or a patient without teeth, who has very different expectation long term about what their teeth are going to be like, what chewing is going to be like, and what life is going to be like with changes in their dentition that will happen with head and neck cancer treatment. Some patients have more complex needs as well, and some of the surgeries entail things other than just teeth, including skin or the inner lining of the lip, which has really profound consequences for patients as far as long-term being able to maintain dentition and have functional dentition as well. So for me, a lot of it is setting expectations for patients and understanding where they're coming from and help guide them to understand where they're going as far as their teeth long term. So when patients come into my office, the things that I initially to be thinking about, number one, is are there any teeth that need to be removed in order to remove their cancer? This is typically the number one goal. If we can't give them adequate surgery for the cancer, the whole game is lost. What is their pre-existing dental status? Do they have teeth? What's the condition of those teeth? Sometimes even, like you can see here in these teeth, the occlusion or how the teeth come together is altered by the underlying tumor that's there. Can we reestablish that occlusion or how the teeth come together? Or is that going to be possible for the patient? These are all things we have to be thinking about and guiding patients through the process. Every patient has different goals for the dental rehabilitation after surgery. Some patients are most concerned about their cosmesis. Some are most concerned about chewing and function. Some patients are most concerned about their speech. Teeth are critical for pronunciation, particularly of certain sounds. And I have one patient who's a voice actor, and his primary concern, he doesn't care about how the teeth look or anything like that, is his speech. And so we have to work with our maxillofacial prosthodontists and dentists in helping patients achieve those types of goals through their treatment. And of course, is radiation anticipated postoperatively? And if we have to remove teeth for surgery, typically radiation is expected. And we've talked a lot about radiation, but there's profound consequences on wound healing and function long term and what that'll mean for the patient as far as their dental status. In the operating room, I'm still thinking about teeth. We're thinking about, number one, like I said, did we address the underlying tumor? Did we give the patient what they needed as far as long-term care of their cancer? The second is, can we reconstruct it in order to move them along into timely adjuvant radiation? Once we hit the time of surgery, we have a narrow time frame for oral cavity patients to get them in for radiation. So we need to have a reconstruction that gives them a safe wound in order to get them onto radiation. That's the second goal. And the third and final goal, on top of all of this, is maximizing functional aesthetic outcomes. But we can only think about this if the first two things have been established from the get-go. And technology is certainly changing in our field. Maxillofacial prosthodontics is evolving as well. And more we're thinking about long-term dental rehabilitation, but not without the first two goals have been achieved. So once we do get them through surgery and radiation, as a head and neck cancer surgeon, I see patients regularly to help them with a number of issues. Usually I'm seeing them for the first couple of years, every 2 to 3 months in the office. This includes careful examinations and the ever-beloved laryngoscopy exams. I'm ordering scans, addressing functional issues that we've talked about, evaluating for any other complications that inevitably can arise, osteoradionecrosis, hyperthyroidism, xerostomia, or dry mouth, and discussing physical and mental effects of treatment. For some patients, these are quick visits, 5-10 minutes. For other patients, this is an hour. And it really depends on where the patient is along their journey, what issues they're having. And we continue to follow them for years thereafter. But this is probably the most important slide of what I'm about to tell you as the head and neck cancer surgeon who sees my patients. And this is one of the most common questions I get when I'm seeing patients for surveillance long-term after their cancer care is, doctor, what do I do about this tooth? I'm seeing patients very frequently for years, and so I'm oftentimes the most visible person in their cancer care. And the thing that I tell them, and this is what I encourage all patients to say to their, or what I encourage others to say as well, is I don't know. As a surgeon, I don't know. I'm not a dentist. You need to see a dentist who had significant experience with patients with radiation, and the dentist needs to ask for your radiation fields and review your radiation fields before any major dental work is done. You can have cleanings and examinations with the local dentist who you know and trust, but with any major dental work, you need to seek out someone with significant experience with radiation. I'm sure that's not possible everywhere. Fortunately here, we have great colleagues in dentistry that we work with at UCLA who, if I send you there, I trust they're going to be reviewing your radiation fields and making good decisions to help prevent longer-term complications. So the complication, the one that we're all concerned about and thinking about and have all talked about, is osteoradionecrosis. And there's really a whole range of osteoradionecrosis that does arise. This is defined as chronic bony exposure, typically inside or outside the mouth after radiation treatments. It can show up any time, but usually within the first 2 years or so after your treatment. For early stage disease, there are medical treatments that are available, and in fact, there's significant data that it's effective. I hand out pentoxifylline and vitamin E like candy in my clinic. And there is some data to suggest that this halts and in some cases can reverse some early stage osteoradionecrosis. In later stages, I'm involved in larger reconstructive surgeries to reconstitute the bone that's been lost from the radiation and osteoradionecrosis. But of course, we're all trying to avoid that, our patients having to have bigger surgeries down the road, and if we can, catch this early. Some patients also receive hyperbaric oxygen treatments. There is some mixed data about this, and not as today is not the most commonly used modality, but some patients seek that out as well. And finally, I was asked there is going to be a whole session on this later on xerostomia. I was asked to briefly comment on this, and I think I'm about out of time. But for our patients, we are constantly, you probably see there's a lot of water bottles in the room, a lot of constant water sipping, using lip balms to help retain the moisture inside the mouth, humidifiers at home, and careful regulation of the humidification of the home environment. Sialagogues can include typically sugar-free sour candies is what's recommended. There are sialagogue medications. So sialagogues are things that help stimulate salivary flow. This include medications like pilocarpine, although that needs to be carefully weighed with your physician as far as some side effects that can arise with these cholinergic medications, as well as salivary substitutes like biotin and others that have been mentioned. So those are the prevalent dental issues that arise in my clinic, and I do thank you for giving me the opportunity, and thank you to Eileen for helping with all the last minute changes to my slides too. So.
Okay, thank you to our panel, and let's open the floor for questions. I was asked to make sure that questions are short enough that we can remember them and answer them. That's for one of our board members at the back, but maybe anybody else. And then we'll take some online questions, and we're going to alternate between the people here and the people at a distance. So any questions or comments to start?
We have one here.
Hi, my name is Kyu Ho. I'm a head and neck radiation oncologist with UCI Health. I had a question for Jamie first. Thank you so much for sharing your story. So my question is, there's obviously no good time to have cancer, but 2020, I imagine, would be like the worst year to have cancer. And I imagine cancer-directed treatment was already limited at the time, so I can't imagine how limited the care necessary to fight acute and chronic side effects are. Can you share a little bit about what resources were available for you at that time? And even if you had access to online videos and things you can do on your own at home, I think it'd be good to know, heavens forbid, a pandemic happens again, but of course having alternative resources where we can do the best we can in the situation would be great.
Yeah, so I know you guys tell us not to Google, but we Google all the time, and I look up YouTube, when for going through surgery, and then radiation was harder because I had to sit in my car. They would text me when to come in when the room was ready. And then sometimes it was shut down that day, so then I wasn't able to do treatment. But then they would emphasize, you have to make sure you do it every day. And then I go, but you told me I couldn't come in because everyone has COVID. And it was really, really stressful. So a lot of the communication wasn't great. So I would go to YouTube. I'd be like, what do I do? What have other people done? And that's a big reason why I share on social media, so other people aren't going to be looking on YouTube like I did. And we've come up with this whole young peer-to-peer support group called the Young Tongues, and we have this whole forum where people share what works for them. Oh, I've never heard of that. Well, let me try that. That'll work. So it was just a lot of I Googled and trying to figure it out. But that was during COVID, so it might be different now.
Thank you, Jamie. I also want to remind everyone the Head and Neck Cancer Alliance has a lot of wonderful videos and webinars that have been done over the years, so that's another resource going forward. I think we have another question in the audience.
Is it live? Oh, good morning, everyone. I just want to point out something that may help you all. My wife and I were informed Medicare has just recently approved payment for the compression pump when the claim is submitted by your therapist. And recently, as recently as a month ago. But I do also want to make a comment about being a caregiver. I've been blessed to be a caregiver 3 times. God puts you in places at times that you can't even imagine to perform deeds that you never thought you would or could. So please take care of yourselves, because the person you're caring for needs you to take care of yourself. Thank you.
Thank you. Thank you for that comment to, as not only to caregivers that are individual for the patient needs support, actually the medical team does need that as well, and I think many of us would appreciate that specifically. I'm going to take a question from online, which was a question about reconstruction. So there was a bone replacing the mandible, a fibula transplant. Now my jaw or teeth are removed on the left side of my mouth. Is there any option for creating something to chew on that side? And I'll pass that over to, I think, our first two, the dental and the surgical team.
Sorry, can you repeat that question one more time?
Just fibula replacement, and now that that's done, can there be dental replacement?
So the answer is yes. That generally is a very complicated question. It depends on the radiation that's been given, the status of the reconstruction, and that kind of rehabilitation takes a lot of work between a surgeon, a dentist, maxillofacial prosthodontist. There's a lot of different options, whether that's born into the bone or whether the dental rehabilitation is borne by the other teeth, and things like that. So the answer to that is yes. I will say that can be sometimes a long journey for patients, sometimes very complicated, sometimes unsuccessful. But for patients who are motivated and willing, with the right team, it is possible.
Any comment, Dr.
Yeah,
Sung?
I think that's really a key component of the answer to the question. So the team concept is really important because when you place the fibula or the bone to that site, it needs to be coordinated with whether it be a maxillofacial prosthodontist or the dentist or the dental side of the team, because the bone needs to be placed in a very critical location where there's room for dental implants and the teeth above it. So on our side, we often see bone being placed, and if there's no room, it makes it very challenging. However, when it's done in coordination, we can restore those areas with dental implants and teeth. And sometimes we use prostheses that are not associated with implants. So that takes even a different level of expertise. So I think the coordinated care is the most critical part.
Yeah, and that gets back to the team approach. And I think actually Dr. Larson showed some three-dimensional treatment planning models with the pre-planned surgery, often now with pre-planned implants placed at the time of surgery. So there are real advances in the potential for reconstruction. And in general, fibula transfer is an area where there was not radiation at high dose, but not always, and all that needs to be planned. So hope that was helpful. Next question. Yep.
Good morning, and thank you for all that information. My name's Alan Davidson. I live in Colorado Springs, Colorado. I was diagnosed with a squamous cell carcinoma, P16 positive at the base of my right tongue in 2021, and went through chemoradiation therapy after that. This is directed to you dentists, and actually to our association here. There do not seem to be many dentists who are directed and knowledgeable in this area at all. So when I asked my providers, my medical providers, can you refer me to a dentist that has special knowledge or at least special awareness of the problems that you all have discussed this morning already. In the community I live, which is almost 1 million people, there wasn't one that they could provide me a direction toward. So I would ask our association and your affiliations to see if there's a way that you could put together a list of dental providers that have special interests, special knowledge, have thought about this, know what the risks that occur in long-term follow-up are, know what to look for, know what to prevent, know what to be very cautious about in the post-treatment follow-up of this. If there could be something put on a website or just a list of providers available that have the special knowledge and the special interest and the special desire to help.
Yeah, I agree with you. It is very limited. I mean, I provide the dental students a lecture. I used to provide a lecture series on this topic. Our team used to, and due to limitations, it became a little bit less. So it's now down to about an hour, which is really doesn't do it justice. We also go give lectures in the community, but it's one of those topics that's probably not as, I mean, if you look at the number of patients with that, I think, unfortunately, the desire may be a little bit less to attend this type of talks. Having said that, there are organizations that deal with this. It would be the Oral Medicine Organization, and is it American Academy of Oral Medicine, AAOM?
Yeah, yes.
Okay, that's one group. Then there's maxillofacial prosthodontists, and that's also, I believe, is American Association of Maxillofacial Prosthetics, AAMP. And then last group, that's, I don't know about the size of it, meaning how many are in it, is the Special Care Dentistry Association. And within that group, there's a hospital dentistry group, which the focus is, again, on the integration of medicine and dentistry. So if you contact those organizations, they may be able to provide a list. I'm very involved in the Special Care Dentistry Association. I know when patients call up to ask for expertise in that location, the organization usually tries to give names that has exposure or a higher level exposure that may help.
Yeah.
Okay. I hope those three resources will be a little bit of help.
One of the things that I also recommend is if you can't find that individual through the cancer center, they will often know who works. They may have an identified community dentist. They may have a dental program in the institution. Many of the bigger centers actually have support internally, and they're obviously more potentially and easily integrated in care. But in the community, there will be people with potentially more experience. And one way to look for that is dentists in the community who have done a hospital dental residency, like Dr. Sung's program here. They will have been in the hospital, not necessarily focused on oncology, but understand medical and see oncology patients as part of their training. So they will have that extra additional level of knowledge base. Also, we as a group and an organization and the various specialty groups are available to provide information and guidance to, say, a community dentist so you can receive the care you need where you live. But I think one of the opportunities to look in the community is a general dentist with hospital residency training, and that really provides an additional resource in many communities.
Hi, my name is Chris Billmeyer. I'm also a cancer survivor of HPV tonsil cancer. I just wanted to reiterate on what Jamie mentioned earlier about the psychological side, as long as the gentleman, the doctor over there, during treatment. I was diagnosed in 2020 at the height of the COVID pandemic as well. And during that time, it was very hard, like Jamie was saying, that you don't have support or people that can go with you to your appointments and hold your hand and give you encouragement. One of the things that I found that really helped me was my care team. They were very supportive in helping me, but they also gave me direction on how to cope through support groups. And then I found the Head and Neck Cancer Alliance. Those people, too, were immensely helpful with the resources that they have out there. The other thing that I did during my treatment was, in order to just kind of talk to somebody, as I'd go down to the waiting room where other patients were getting their treatment, and strike up conversations, because I just couldn't sit there and go, gosh, I can't do this, you know. And that helped. So there are a lot of resources out there for everybody that is in treatment or going through treatment, and even after treatment. So you're not alone in this journey, and there's always something out there, but definitely during a pandemic, it's much more harder. So stay strong, everybody. Thank you.
Okay, another question from the community is, my radiation oncologist provided or prescribed pentoxifylline and vitamin E for fibrosis. Dr. Larson mentioned this as a surgeon that it's often utilized. Can you comment on whether it may be beneficial for dental issues was the question.
So the context when I typically prescribe it is early osteoradionecrosis, which is really a dental issue in and of itself. I don't know if there's other issues that you use it or prescribe it for, but
yeah. So basically, I think then it was deferred to me. The medical management that will enhance tissue repair. So, for example, there are studies showing better surgical outcomes, say if a tooth needs to be removed and there's no other options, by pre-treating with pentoxifylline or Trental and vitamin E, but also, again, with red light therapies to promote wound repair. And there is prospective evidence that that is useful in that kind of setting. So the other value of those medications may also be in management of fibrosis, which was another question, but that goes back to, I guess, the first panel. I don't know if you have any comments. No? Anyone else? Looks like Dr. Vila at the back was going to get up and say something, but I'm not sure. No, he's not. Okay. There are some other questions related to insurance coverage and chronic dental care needs. And I think we have two people that have been trying to deal with that in the room relative to Medicare's planning, but whether it's functional is still the question. So, Dr. Sung, you've got the microphone. Maybe you could take that one on.
Yeah, Medicare has authorized the reimbursement for dental treatment post-radiation therapy, those that are associated with that. So I'm going to say at UCLA, we've been trying that to bill for procedures through Medicare associated with post-radiation patients. Unfortunately, we haven't had any success. We've been working from our perspective really hard to try to make it work. And so far, it hasn't been too successful. We have been in communication with the dental officer for Medicare in California, and his comment to us is, please keep trying, and I'm working on our end to make it work. I wish I could give you better information about that, but right now we haven't been terribly successful.
My understanding, that's the national perspective as well. The principle has been established in I guess, law, but it hasn't been translated to functional reimbursement support for care needs that are directly attributable to cancer or cancer therapy yet. Although the upfront treatments, for example, dental extractions prior to head and neck cancer therapy and some others are reimbursed. But that's still where we're kind of stuck waiting for clarification and actual functional reimbursement.
Hi, I'm an oncology dietitian and one of the clinical navigators at a cancer center at Sharp in San Diego. I share that with my friend Nancy here. And one of the radiation oncologists that we work with came across a study that was published in January of 2024 using a oral probiotic during active radiation treatment to reduce the effects of mucositis. So we've started implementing that in a lot of our head and neck cancer population, and anecdotally, we're seeing some positive results where people seem to be doing better by the end of treatment with less mucositis. So my question for the dentist is, what data, if any, are you familiar with post-treatment and using probiotics to maintain a healthy microbiome in the mouth and to reduce fungal infection and chronic fungal infection in dental caries?
I'm not as familiar with any specific studies. That seems to be larger than the case series. So I don't have a good answer for that. Probiotics and different aspects of throughout my career, there's been many different ways to try to decrease mucositis, and in certain centers they have found success. I'm not giving a great answer because it was not translating very well to the overall population. And the problem I often find, and perhaps Dr. Epstein can give you a much better answer, but the problem we often find is the variability within head and neck cancer. Again, I kind of alluded to that during my talk. The location is the side effects, depending on where the primary lesion is, can have such variable types of outcomes. And so when they do studies that are translated into a greater population, we found that it's hard to make it a well-defined study, because they'll include this versus that, and the dosing's different. And whether it's chemo, and depending on what kind of chemo they were using, which trial they're using, it made the outcomes so variable. So circling back to what I was saying, a lot of times as a dentist, you need to remember that information, that it's highly variable between a nasopharyngeal versus a base of tongue lesion versus, anterior of the mandible or floor of mouth, whatever. And again, even within treatment, it's so different from center to center in a sense of access to a maxillofacial prosthodontist, someone who can make a tongue depressor appliance versus something else. The outcomes then do become different. So sorry, I didn't give you an answer. It's a non-answer, and I apologize for that, but I would be interested to find out. Yeah.
Yeah, so the question was, this is actually relatively new and in a developing field. The GI microbiome is better understood, and even that the research is really new, just developing. It never made sense to think that the gut microbiome was the only thing that had an effect systemically and for cancer risk and, in fact, cancer recovery, because the oral cavity is also colonized, and of course the colonization is different. So the oral microbiome as a separate compartment actually needs now to be addressed. And there are some commercial companies that are producing oral pre and probiotics, but they don't have the data. They need to collect the data. I do use an oral pre and probiotic for people with recurrent candidiasis or recurrent yeast. And once the antifungal effect is passed because you stop the therapy, it may reduce risk of recurrence because the colonization sort of crowds out the space for the yeast to overgrow. And that has potential. That also still needs data to say that it's an appropriate thing to do. The other thing that is actually being looked at actively is oral flora and second cancers, and primary cancers, oral, but not just oral, lung, prostate, pancreas, have all been correlated now with certain oral microflora that are colonized in some patients. But that correlation doesn't prove cause and effect, but it's how we start to look for those interactions. So potentially we will be treating the oral microbiome in different ways, potentially for different conditions, but the data is just developing.
We have time for one more in the audience, and then we'll need to make sure to have time to switch to the next panel. So please make sure to write down your questions on the index cards, and we will get to them.
Thank you. Hi, good morning, everyone. My name is Nutan Sangani, and I'm a mandible cancer survivor. My surgery was done last year, and I had gone through the same kind of surgery. My jawbone was replaced with the fibula bone. And currently, I'm having some oral hygiene issues, and I would like to get more knowledge, like how I can educate myself. So what kind of special doctor I should see for the dentist world? Like, I've been seeing my dentist regularly, but seems like I'm not getting much advice related to the radiation treatment. So I'm really looking for some help. Who should I see for that? Thank you.
Yeah. I don't know your location, but as we kind of alluded to, a dentist that has hospital dentistry residency experience, they should have a higher level of experience specific to what you have. Now, another component is a maxillofacial prosthodontist, which is a subspecialty of dentistry, and it's usually as a prosthodontist that has maxillofacial prosthetic training. So they are the ones that typically have the greatest experience in, the complications or side effects that you're mentioning. Okay.
Okay.
I hope that's helpful.
Okay, thank you.
Okay, so in closing, I have to thank the organizers again for the title, because it sounds like you agree with us that the mouth matters. And this is usually a good time to present just before lunch, but there is another panel, because you can enjoy whatever good function you have and taste function and saliva function during the meal. But the fatigue lecture is at the end of the day, by the way, just for all of us, especially those who have just come back from Africa. And you probably don't know this, but the moderator or the chairman of the session, Mike Moore, was just there for surgical management in a surgery team and flew here without going home. And still alert and awake and his great, wonderful self. So I think in summary, though, we've sort of emphasized the need for care teams, integration, looking for people with expertise that you may need in the community and also through cancer centers. So with that, I'd like to thank our presenters, Jamie and Dr. Larson and Sung, for participation and planning with the group. And I'd like to then move to introduce the next session, which is Navigating Treatment and Survivorship Through Shared Decision Making. And I hope I say the last name correctly, is Dr. Shoa is the chair. Thank you.
All right, thank you guys for having me. I'm Josen Choa. I'm a head and neck surgical oncologist and reconstructive surgeon over at the University of California in Irvine. Such a great conference to be at. This is actually, we go to scientific conferences all the time where we interact with other surgeons and the oncologists. This is the first time I've ever been at a patient and provider conference, and it's so valuable. It's amazing that more of these don't exist. And we hear the comments in the group, and everyone is hungry for support and support network, and something like this is so important for patients and for providers to hear what patients are going through. So thank you for having me. Our topic here is shared decision making. And shared decision making describes this kind of collaborative process that physicians and providers go through with their patients. And it's to try and come up with an understanding and a way to make decisions together using the expertise of the provider and taking into account the values and preferences of the patient. And so really it's central to a conference like this. Really the question is, how do we understand what patients want and use the knowledge that the providers have to make the right decisions? And it's different, not just by disease process, but it's different by individual, and that's so important to recognize. There's a lot of different models about shared decision making, but ultimately it comes down to the provider being able to define the problem. Why is head and neck cancer important? To find the solutions to that. We have radiation, we have surgery, we have chemotherapy, we have immunotherapy, and then talk about the risks, benefits, pros, cons of each of them, but ultimately to also take into account what does the patient want, what are the patient's values, because none of that knowledge means anything if we don't know how it affects that patient that's sitting in front of you. So shared decision making necessarily takes into account all of that. And it also takes into account how much the patients want to understand. All of you are here today, so we know all of you want to understand more about the disease and the treatments that you're going through. But some patients come and they really don't want to know. They just want to be told what to do. And it's important for the providers to recognize that. So in this session, we're fortunate to have a diverse panel. We have a physician, a nurse practitioner, another physician who's the medical director of a palliative care program, and a cancer survivor. Together, they'll explore how collaborative conversations between patients, caregivers, and providers can lead to more personalized and effective care. So we can get started by welcoming each panel member. Julia Porter, she's our first speaker. She's a survivor. She's a speech pathologist at Indiana University Health, and she's also a survivor of adenoid cystic carcinoma. Julia is going to share with us her personal cancer journey, how she navigated fear and anxiety, and the strategies that she uses to overcome these challenges while helping others do the same. She's also going to talk about why shared decision-making is so important to the patient, loved ones, and the care team. Next, we'll have Dr. El Magami. She's the chief of the Division of Head and Neck Surgery at City of Hope, which is another National Cancer Institute designated comprehensive cancer center. Her team offers patients the latest in evidence-based care, access to modern technologies, supportive care medicine, and leading-edge research. And she has a fierce commitment to outstanding personalized care. Dr. Jessica Kaltman will speak next. She's the medical director of outpatient palliative care, and she's an assistant professor at UCLA. She provides specialized care for individuals living with serious illness, focusing on complex symptom management and offering compassionate support to patients and their families. Her work is driven by a commitment to advancing innovative outpatient palliative care models that reduce healthcare disparities, improve quality of care, and promote emotional well-being at the end of life. And last but not least, Beverly Garber will talk. She's a doctorally prepared adult nurse practitioner who specializes in otolaryngology, specifically head and neck surgery at UC Davis Health. She provides comprehensive care for head and neck cancer patients and their families, emphasizing a patient-centered, team-based approach to treatment, surveillance, and survivorship. She's also a certified tobacco treatment specialist, supporting patients in tobacco cessation efforts. Her research interests focus on depression screening among head and neck cancer patients, as well as quality improvement strategies to improve timely, guideline-adherent care. So first up, we'll welcome Julia Porter.
Okay. So yes, my name is Julia, and that was me in the photo back there at the beginning slide. I realize I need one of those poll things so you guys can vote on the blonde versus brunette. But anyways, I am the survivor panelist, but I'm also a speech pathologist, and while I can only take one of those hats off, there's still definitely going to be a bit of an SLP layer here. But I'm from southwest of Indianapolis, born and raised. I work north of Indianapolis at Indiana University Health. And being in LA brings back some really good memories for me. In fact, the last time I was here was 9 years ago, when my husband and I landed at LAX to start our honeymoon journey up the coast of California. We rented a convertible. We thought we were really cool and original until we saw like 1,000 other couples doing the exact same thing. But it did hit me when we landed this time around that was really my last, I think the last trip I took before my cancer diagnosis. Because a few months after getting home, I started to experience these, again, that's kind of the theme here, some weird symptoms. First I thought maybe it was just the changing seasons. Then I thought maybe I had a cold. Then suddenly it was spring and maybe I have allergies. But eventually it became something that I couldn't ignore any longer. And that thing ended up being stage 4 adenoid cystic carcinoma of the sinuses and the skull base, and then really kind of hit the ground running. Anytime you hear that, the C word, I think as it was called earlier, suddenly a lot of decisions need to be made, a lot of conversations need to be had. You're kind of told where to be and when to be there and who you're gonna see and what day, but I have work and I have this. Nope, you're gonna go see this person at this time. I was fortunate enough to be able to have A, treatment options, and B, options or choices of where to go to pursue those treatment options. But however, as Wade alluded to earlier, sometimes having choices can kind of muddy the waters a little bit. I mean, these stakes are so high, like this is literally your life, that you're choosing, where and who to put your life in their hands. But through it all, I really was an active participant in those decisions and those discussions about my care plan. And this really helped me make informed decisions about where to go and what to do. And so, what does it mean to be a participant in person-centered care? This is care that's delivered in a setting, in a manner that's responsive to individuals and their goals, their values, their preferences. It's in a system that supports good communication and really ultimately should empower people to be able to make effective care plans with their providers together. And so, again, my providers, kind of regardless of their specialty or institution, were able to kind of present that information to me in an unbiased way and in a way that I ultimately understood. And so many of you in this room are survivors, and so maybe these conversations aren't necessarily about how to treat your cancer, but how to deal with the things that you're living with as a result of your cancer treatment. Again, for me, a lot of that was and still is, fear of cancer coming back, trying to kind of move on to that after treatment life with hopefully the rest of my life ahead of me. How do I approach those decades of decision making about family and things like that? Cancer already kind of took me for this ride. Now I have all this to deal with. So how do we take some of that autonomy back? We can name what's important to us, to ourselves. We can name that to our care team, to our caregivers, our family. We're all thankful to our oncologists for saving our lives, but telling them what you're dealing with as a result of what they did to you to treat that cancer is okay. It's not going to make you any less grateful. They're not going to think any different of you. Tell them what you're still dealing with, report those things and how it's affecting your day-to-day life so that you can get connected to the things that you need to adequately treat it. For example, your speech pathologist knows that swallowing is important to you. They know how swallowing is important in their own lives, but maybe adding some context to that in your visits of, I need to be able to eat at the dinner table with my family. Our Sunday dinners are sacred to us, and this is why I need to be a part of it. How can you help me be a part of that interaction that's so important to my life? And again, some other options up there. Other tools I like, your providers are obligated to present information to you in a way that you understand. If you don't understand, please explain this another way. I don't think I'm following you. Please go over that again. That's within your right as that patient being an active participant in your care plan. And of course, I do want to say, if you're going to record conversations, if you can't bring that extra set of eyes, ears, just make sure you ask permission first. Some institutions might have rules about that. And I think it's also important to note that it's okay not to advocate every time. It can get really tiring to be in that role. And because I can't take my speech pathologist hat off, I do also know that maybe many on the call or virtually or here in this room might have had some really personal conversations with their speech pathologists about how to deal with or manage this dysphagia that they're living with. And so I think some of these questions are important to ask. Are there other things or procedures, therapies, et cetera, that could help me reach my goal of sitting at the dinner table with my family and enjoying food? What specific factors have you taken in consideration when making this recommendation? We shouldn't make diet recommendations lightly. Management of aspiration, management of swallowing challenges after head and neck cancer, or swallowing challenges in general, is not a one-size-fits-all approach. So what does your provider know about you, and how are they taking that into consideration when determining or making the care plan with you? So again, can't take that hat off, but I will leave you with a quote from someone that I found, make sure I'm on the right slide here, okay, who I found early in that Googling phase of diagnosis which Google was like super depressing at that time. You know, stage 4, cool, that's awesome. Oh, it's solid type, that's got a negative prognosis with it, cool, okay, that's what I have. Oh, I have Notch1 mutation, also not cool. But in all of that, I found someone named Gabe, and she was actually dealing, I think, with her second bout of adenoid cystic around when I was diagnosed. And finding her just was really inspiring to me because I was like, here's somebody who's living with recurrent adenoid cystic carcinoma who's just really living out loud with this. I mean, cancer really is the most hostile of takeovers. And I think that, you know, this quote, being brave, it really means not giving up on those things that make you feel alive. And that can be really vulnerable to admit, this is what I really want to do with the time that I have. And that can be really scary. And so when you do that, you're brave. And that to me is what bravery means, I guess. So anyways, thank you.
Greetings. Nice to be here. Let me get myself situated. I don't have my, I can use a little assistance here. I can't imagine my life one day without speech and language pathology on my team. Everything I do as a head and neck surgeon is really, you know, based on them being able to partner with me and help my patients recover speech and swallowing function and become whole again. I want to thank the meeting organizers, the Head and Neck Cancer Alliance, for this opportunity to speak to the very important issue of shared decision making, which is really paramount for success in oncology. I am here on behalf of my entire division of head and neck surgery at City of Hope, and it's an absolute pleasure for me to be here. Thank you for the invitation. Julia, you are a speech and language pathologist. My hat off to you, but thank you for being the patient champion on this panel and bringing your perspective to this. Co-panelists, really nice to meet you and be in your presence. So these beautiful people that you see here are a number of my patients who I've had the privilege to care for over the years. They are multifaceted, beautiful people with dreams and aspirations and family and loved ones who love them and live for them and care for them. As you can see, head and neck cancer comes in different forms at different ages, different genders, and people from all walks of life can be afflicted by this condition. Just look at this room. Just all of you are beautiful and very colorful, and this is really a wonderful session, being able to share, you know, my perspective from a provider, and it's just a wonderful experience to be here with you. As a head and neck cancer surgeon, I learned very early on in my career that good decisions are not made alone by the MD team. And, you know, the best treatment plans are those that are formulated together with patients and their loved ones in a shared decision-making process. For sure, curing the disease when possible or alleviating pain and suffering are our top priorities as cancer providers. Nevertheless, we must tune in. We have to attend to each patient's individual situation, values, and priorities to achieve best results. Sir William Osler said it the best. This is a famous quote from him. He's a famous Canadian doctor over a century ago. At the time of his death, he was the most famous physician on the planet, not because of some huge groundbreaking technique or discovery, but because of his humanity and because of the style of doctoring that he brought to the patient's bedside. So shared decision-making is absolute key for successful doctoring, especially in the field of oncology. It is important that we help patients make informed decisions that align with their values and with their life priorities. And, you know, if you're an older patient, you might prioritize autonomy, independence, and quality of life over duration of life. But if a younger patient with a young family at home, you're going to prioritize life duration over all else because you want to be there to nurture your children and see them to grow into adulthood. treatment of head and neck cancers can be complex, and deciding between them can be quite difficult and a daunting task for patients. It is important that we be honest and open in our discussions with patients, give them the time and grace they need to process the information. We have to paint a fair perspective on different treatment options that are available for patients and take the time to review pros and cons of varied treatments. It is important that we welcome and engage caretakers and loved ones into the conversation because they bring a whole different perspective to the meeting. The interactions that the physicians have with patients is very intense, and they happen in these very condensed short periods of time. The perspective that the caretaker, the family member brings into this heated discussion is extremely invaluable because otherwise we can lose sight of some of the important things that are important to each individual, unique patient. Important facets of a patient can be easily overlooked in our fast-paced, demanding lives as oncology providers. We need to remind ourselves to be patient with our patients and to be curious, to dial into specific patient needs and nuances that ultimately influence our success in the patient treatment experience and final outcomes. What is best treatment for one patient may not be available, appropriate, or acceptable for another patient, so things to keep in mind. So I want to share an example of shared decision-making that happened in my recent practice. I chose this patient in particular because it's a common scenario in modern head and neck oncology practice in the United States. And despite the many recent advancements in the treatment of this particular disease that I'm about to discuss, the best standards of care are still widely debated, and there is no one best standard. The title says case study, which is really trade jargon, formal and impersonal. In reality, this is a true story of a human being, someone's loved one who walked into my office one day with his entire world turned upside down on his head, with a new cancer diagnosis and all the uncertainties and devastation that goes along with the C word. On any other day, this could be any of us in this room, and this particular human happened to be a man that was happily married to a loving wife, gainfully employed as an engineer who had never even smoked a cigarette in his entire life. So, I'm sorry, I'm going to go back. He presented to his primary care doctor with a left neck mass. And his primary care doctor ordered a CT image and referred him to an ENT. Long and the short of it is he got diagnosed with HPV-mediated tonsil cancer, which is a common diagnosis in our clinics. As is usually the case, PET scan is done to kind of get a sense of disease burden and distribution in the body. So one was ordered for him at our cancer center. Unfortunately, he had the incidental finding of another cancer on top of the tonsil cancer at the same time. So the PET scan showed a kidney cancer that he had, and the urologist said he's going to need to have his kidney removed as well. So this poor guy is having parallel discussions with the head and neck team and the urologic oncology team, trying to figure out what to do and how to balance the different treatments of the two diseases, in parallel for himself. I, as a head and neck provider, took him to head and neck tumor board, and after reviewing his data, we decided that, well, he has a surgery option, but he also has, chemoradiation as an alternative option. And so it was upon us to discuss the pros and cons of the different approaches to management to help him make an educated decision that would be best decision for him and for his family and life circumstances. So when I was a resident at this fine institution that's hosting this wonderful meeting today so many years ago, which brought nostalgia back of the younger version of me when I was running around campus over here, on the left, you see what was surgical, possibility for tonsil cancer back then. To get to a tonsil cancer as a surgeon, I would have had to place incision on the face. I would have had to break the jawbone. I would have had to, get back to the back of the throat to cut the tonsil out. And then a reconstructive surgeon would have had to partner with me to transfer tissue from one part of the body to the back of the throat to do the reconstruction. And then a very intensive program of rehabilitation would be necessary to try to restore swallowing function for the patient. So then came along recently robotic technology and robotic contributions to science and medicine. And there were technical evolutions in the treatment of tonsil cancer, including use of robotic technology for management of tonsil cancer, which now allows operating through the orifice of an open mouth without having to place incisions and scars on the face, without having to break the jaw open. So in a matter of 2 hours, you can potentially go in with robotic instrumentation, snake-like cameras, snake-like instrumentations for surgery, and cut the tumor out and potentially render a cure. So surgery became attractive again for management of tonsil cancer, whereas before robotics, what was happening, patients were being treated with radiation or chemoradiation therapy, trying to avoid the facial scars and the disfigurement and potential swallowing difficulties associated with radical open surgery. So we offered the patient robotic surgery at City of Hope, but we also discussed chemoradiation as an alternative option. There were pros and cons for the different approaches for management. Favoring robotic surgery was the realistic possibility of having lesser radiation therapy after removing the tonsil tumor with the robotic surgery device. But more importantly, there was an option, there was a true possibility of avoiding chemotherapy altogether in this patient, especially given the fact that he had one kidney and we had to do everything we needed to do to preserve the one kidney going forward because of the nephrectomy he needed for the other cancer that was diagnosed. But, in the second or third visit, what came along was the fact that he had sleep apnea, and he was using a CPAP mask during sleep every night. And I'm sure there are people in this audience that have sleep apnea. It's a common condition, but it's a situation where the patients just don't have enough air when they sleep, and they have to wear a positive pressure mask over the nose to keep the airway open so they can have good oxygenation as they sleep and get a restful night sleep. But the problem is, after robot surgery, you have a raw opening and a wound in the back of your throat, and you cannot have positive pressure appliance on your airway. So the sleep apnea was a relative contraindication, or at least a relative concern for us surgeons for going forward with robotic surgery. So to offset that concern, he went and met another robotic surgeon in the community for an independent discussion separate from me. He also met with the radiation oncologist at the institution to discuss radiation as a treatment approach and chemoradiation therapy and what that might look like and what to expect after that. So just to cut to the chase, we had 4 separate pre-op discussions with this patient to discuss varied options, and thankfully his wife was there every time and extremely supportive and very, very, very involved in the discussions and helped guide, his ultimate decision to go forward with robotic surgery. So thankfully, he had the robotic surgery. Surgery went well. He didn't have any issues with his airway, no bleeding. He didn't need to, be trached or have intubation or any other intervention for airway distress. And we were able to send him home on a soft modified diet as is usual after his robot surgery. His pathology was favorable in that his margins were negative. However, because he had one metastatic lymph node, he still required addition of radiation therapy to the surgical program. But, thankfully, we could give him lesser dose of radiation therapy. Lesser dose means less toxicity, less dry mouth, not like what's happening with me right now. I'm having a hard time even finishing my sentence. But, we were able to do lesser radiation. We didn't need to do chemotherapy. So yes, hooray, objective met. So he went on to get his nephrectomy. His kidney cancer was removed. That operation was successful, thankfully. And, 6 weeks later, he was able to start his radiation program, on schedule. He completed his radiation. And with my amazing speech and language pathologist, he was able to rehab and recover, and he's eating a regular diet and doing well and back to life. So I will end this story on a positive note and close with one of my favorite all-time quotes, as it captures the very heart of shared decision-making, and it just so happens that it was spoken by one of the founding fathers of City of Hope. "There is no profit in curing the body if in the process we destroy the soul. The quote reminds us that true healing is not just about treating the disease, but about honoring the whole person, their voice, their values, their humanity. It's about helping people live their best versions of life, to live their best lives. It has been an honor for me to be an oncology provider. Thank you for giving me the opportunity and privilege, and thank you for your attention.
Thank you. Once again, I'd like to thank the organizers as well. I'm really honored to be part of this panel today. I'm Jessica Kaltman. I'm a palliative care physician, which I know as a palliative care physician often sounds like a scary term to so many people that get cancer. We're really a specialty that helps patients walk through their cancer treatments no matter what the outcome might be. We help manage your symptoms. We help be a sounding board when the big medical decisions feel really, really overwhelming. And we also want to just make sure that you're feeling emotionally supported. And if religion and spirituality is important to you, making sure that's well supported too. And so a big part of what we do on a daily basis on every visit with our patient is a lot of shared decision making. So trying to understand what's important to them, what they value, and how that might really relate to their medical decisions and how we can communicate that to the rest of their amazing medical team. So I'm going to talk a little bit about two of my patients today. One topic that comes up a lot is shared decision-making in symptom management. There are so many drugs. There are so many options. And sometimes the drugs we're recommending for symptom management don't match with your lifestyle. There's concerns about driving your children to school. There's concerns about going to work every day. And so oftentimes we do need to sit down and really talk about what might be the best medication or non-pharmacologic intervention that might help manage your symptom while also letting you go about your day-to-day life. So my 58-year-old patient with base of tongue involvement and pulmonary disease of a squamous cell, married, he's got one child, a wonderful writer, came to me after he had had a recurrence with assistance with symptom management. He had neuropathy caused by chemo, joint pains, dizziness, my favorite combination of dry mouth, but also maybe some excess secretions at times, and a significant amount of post-traumatic stress from his previous treatments, thinking about going into treatment again, what it was going to be like, what life was going to be like. And it also was partnered with some depression. So when we talked to him about his various symptoms, he was someone that really, really wants to minimize pharmacologic interventions. So even a Tylenol makes him want to run in the opposite direction, which as a palliative care provider, sometimes you're just sitting there being like, please take the Tylenol. I can see you're so uncomfortable. Please take it. But we also want to respect our patients' choices that sometimes, they don't want to take any drugs to manage their symptoms. So we spent a lot of time talking through things outside of medications that could help. For dry mouth, I have some patients that swear by chewing gum, and that really helps them get through the day. I have a patient I love to talk to nowadays. He can tell me his favorite brand of gum, his favorite flavors, and it really helps him, get through his workday and lets him enjoy food a little bit more. Biotin, which I'm sure a lot of you are familiar with, is one of my favorite choices. Neuropathic pain can be really complicated. A lot of patients don't want to take the neuropathic drugs. They have a lot of side effects. Sometimes their efficacy is not great. And so really sitting down and trying to understand from the patient perspective what their day-to-day life is like and what they need to get done. And then me using my toolbox, I always like to say I have a toolkit, and offering things from that toolkit that matches what they need to get through their day. And it's really, I find it a true partnership in managing symptoms with my patients, talking them through. I always get the inevitable question like, hey, Dr. Kaltman, what about marijuana? Can I use that? Is that okay? And walking through that. And I really enjoy talking with my older patients who have never had a drug in their life, whose grandchildren are like, you've got to try some cannabis, Grandma. You have to do it. But it's, that's just to say there's so many choices and so many ways to manage symptoms. Sometimes we have to be creative. Sometimes we have to gather all our colleagues, our speech therapists, our physical therapists, our nutritionists, our oncology colleagues, radiation oncologists. I can name you guys have such a wonderful team that takes care of you and working together to think maybe outside the box sometimes. Another case I want to talk to you about is some challenges sometimes with shared decision making. Because that comes up too, and trying to understand from the patient's perspective, sometimes they want doctors just to tell them what to do. And sometimes we're spending so much trying to make that shared decision that sometimes it's actually causing a lot of distress on the patient and their family because they are like, I just need that guidance. Outside of medicine, I talk to friends who have had loved ones go through treatment, and they're sitting and they tell me all the time, because sometimes they forget what I do, because they knew me before I became a doctor, and they say, I was sitting with my dad's advance directive, and I was like, I don't know what to do. And I always say, well, you should have called me. They're like, I know, I forgot. That's what you do. But really, the caregiver, that decision maker, there's a lot of responsibility on them to sit down and try and interpret these legal advance directives that exist. What decisions do I make that my loved one, wants? And that becomes really hard. Sometimes I just wish the doctor would tell me what to do, because I don't know what to do. I had a really wonderful patient who had a very, very aggressive form of left lateral tongue adenocarcinoma. She had resections, multiple treatments. She was married with one child. And she initially came to me for symptom-managed support and some early advanced care planning. She was very fortunate that she had access to multiple institutions, multiple specialists, family friends that were in the medical field. But it almost became too much. There were too many cooks in the kitchen trying to guide her care, trying to give her advice. And I think ultimately it led to a lot of overwhelming decisions, a poor coordination of care at times. And what was really hard is that she developed really extensive facial edema after trach placement and eventually lost her ability to fully speak, also lost her vision due to the edema, and so was really stuck in a very isolated place. And I think one of the challenges we faced is we tried really hard while she could communicate to talk a little bit about what her medical wishes are, what was really, really important to her, so that we could involve her and her family in shared decision-making as much as possible. But I think because there were so many cooks and so many players, it just became more and more challenging and resulted in a lot of conflicting opinions, conflicting treatment plans, and some poor coordination care. And I think what really happened was a loss of the patient autonomy. And that's to say shared decision-making is really important, but it's also really important when there's not enough guidance, there's too many people involved, there can be a danger in it. And so for us, always maintaining the patient at the focus and remembering them and what's important to them can really help us guide their care. And just to end with a quote from one of my favorite authors, Barbara Kingsolver, hope is a renewable option. If you run out of it at the end of the day, you get to start over in the morning. And I think that's true for all of us in this room, whether we're dealing with a serious illness or not. I know when I have a bad day and I go to sleep and I wake up in the morning, I like to say it's a new day, new hope. Maybe my kids won't hit each other today. Maybe there'll be something like that. But it's always nice to wake up in the morning and remember it's a new day. So thank you very much.
Thank you all for being here and sharing all of your wonderful stories and expertise. I'm Beverly Garber, I'm a nurse practitioner. I'm very happy to share my experience in shared decision-making. I first want to just mention that I believe shared decision-making as a negotiation between the patient and the caregiver and the clinician. Unfortunately, a lot of the times it's not aligned and the goals are not equal and may be in competition with each other. So I think it's very important to acknowledge that, and in the clinicians in the room to experience that themselves and think back to their time with patients and how
they can provide the care we need to provide as clinicians, but also incorporating their individual goals. The case I'm going to present today is really just an experience the patient presented me with. I just finished healing from a huge surgery. I don't feel ready to start radiation yet. I just want to wait. So clearly, this patient's goal is to rest, is to recover. The time they need to feel better, to feel that their symptoms have improved. And that's hugely important. But as a clinician, I know the time is counting down. This patient needs radiation, and we have evidence-based practice guidelines that direct clinicians to improve outcomes by helping our patients achieve their radiation therapy within a timely manner. So how do we balance that? How do we as clinicians educate patients and their caregivers about the importance of these guidelines while also honoring and respecting their need to rest? There's no answer to this outside of acknowledgement and accepting where the patient is and meeting them there that day. So a lot of times a shared decision is that negotiation, understanding the patient, where they come from, what they need, acknowledging that, but then presenting them from the clinician standpoint on the evidence. I understand this is a very challenging time for you. You need time to rest. We want you to know that your best outcomes will be if we get your radiation started within a timely manner. How best can I support you to achieve that goal? Again, there's no right answer. The patient and the caregiver will often help us in making that shared decision. The next case is someone I just encountered a few weeks ago. This individual just finished their radiation. I'm so overwhelmed. I don't even know what I'm here for today. That was the first thing he said to me when I just walked in the room. And as a nurse practitioner in the ENT department, my goal is to help the patient start their surveillance period, start the post-treatment planning, talk to them about survivorship and their surveillance schedule and their post-treatment imaging. Clearly, that wasn't the conversation we were going to have that day. This patient needed to talk. Being overwhelmed will paralyze you. That information that's given to you as a clinician, you may not be able to absorb. So as a shared decision, the clinician should stop and listen and hear what the patient is needing at that moment. And that's what we did. We just talked. That patient just needed to talk. And that was the shared decision of that visit. And we met again, and then we're able to have another conversation with my goals to help them understand how often we need to see him, when his timing for his treatment imaging might be, and start talking about survivorship. So in summary, and I wanted to keep this brief because I want to make sure we have time for questions, I feel as though the shared decision-making is really a scale. It's never going to be balanced, and oftentimes our goals do not align. But like Julia said so astutely, tell us, as clinicians, we need to know your goals and what you need at that moment, and together we can make that shared decision and negotiate whether it's timely treatment, what you need in that moment, how we can support you. We don't know what you don't tell us, and again, the guidelines will help us give you the best outcomes and survival, but it takes a shared decision to help you live your best life, and that quality of life is very, very important to us as well. My quote is nothing profound, but I've heard a lot today, and we've all heard this, the new normal. I don't believe in that. It is new, but it's not normal. Tell us, speak up, advocate for yourself. There may not be something we can do, but it's important that we share that discussion and those decisions and support you the best way we can. Thank you.
Thank you to all the panelists. What a great, diverse group of perspectives that those came from. I would imagine that there's something in each of those talks that resonated with every single person in this room, both patients and providers. Before we move to the Q&A session, we're going to take a quick poll. So if you take out your phone, laptop, tablet, join our live survey using one of the following options. And then for those asking questions virtually, please remember to put it in the Q&A and not in the chat, and that way it'll come across here. And for the questions that are being asked in person, I'm going to repeat them just so that everyone online can hear them as well.
There we go. Right now? Sure. Okay. When it comes to shared decision making, what's the biggest hurdle? And we have to go back.
I don't know how to get back there.
It disappeared.
Yeah, it looked like it was balancing the risks and quality of life.
So here we are, and it looks like in the lead is balancing risk versus quality of life. Second, understanding of treatment options. And then we have lack of coordinated communication. And then time pressure to make decisions. And then finally, patients feeling unheard.
Thank you. Are there any questions here or comments? We do have one that came through the Q&A, and I'll ask this to the panelists. How does the medical team advocate for an integrated approach? And are you asking about psychological support and strength in your visits?
I'll mention at every visit we do address mental health through a questionnaire with the hope of identifying patients who may be at risk at any point of their treatment journey. But the caveat to that is then access to the support has always been a challenge. So knowing your community resources, asking for a supportive oncology, if your institution has one, can help identify opportunities for mental health or distress. But I will also say sometimes the biggest challenge is there's resources for the patient and less resources for the caregiver. So that's where meetings like this and advocacy with the Alliance can really help connect you with those opportunities as well.
Okay. While others are getting their questions together, don't all jump in at once. I'll ask a question. Tony Askander from Toronto. I'm a surgeon. And the question for the panel is about shared decision-making tools. There's this whole area of research of people using either an app or a video or some other type of interactive tool to help folks make decisions about treatments. I'm wondering if anybody's used them or kind of some of the pros and cons of using them as opposed to just having that personal one-on-one conversation with the patient and their caregiver.
Hi, Tony. I don't personally have any experience using the app, but I know that myself and I'm sure a lot of people in oncology, we just make sure that the patient gets as much access to the team as necessary. So if they need to come back for further discussion, even if it's telehealth appointments, telemedicine, it's hard for them to come in person, but they have questions. And so we're kind of very liberal, allowing for those conversations to happen. And we actually invite them to invite whoever is important in their lives to help, them make up their mind to participate in that. If they don't speak English, we make sure we have translators available so that they can hear it through their own language to be able to process it sort of more directly, one-on-one. So I think that's extremely important. So we just meet the patients and we give them as much time as they need.
I love that. Dr. Lin and I noticed that you've met with the patient 4 times in that case, and so that was a great example of that.
I was going to say, I have not used any apps in my own personal practice, but I do think just in the era of like AI and ChatGPT and everything like that, that really is going to play an interesting role, I think, in terms of now it's like the new Google. I think back probably when I was diagnosed, I probably would have gone to ChatGPT first and maybe would not have found, other resources like Brave Like Gabe and things like that. But I do think we're really going to have to wrestle with some of the information that comes through these big language models and things like that, and learn how to harness it in a way. I remember I had a visit with someone who was in their 80s, and it was my first time meeting them, and I don't think they knew why they were coming to see me, but they handed me something they'd printed off clearly from ChatGPT that was, "What is a speech pathologist?" And so that was kind of a wow, like this technology is becoming accessible to a lot of people. So.
Yeah, those are great answers. Dr. Megami brings up a good point. There's language barriers that we often have to overcome as well in trying to figure out what the patient understands and wants. And sometimes there's cultural barriers, and there's even some cultures where the caregiver doesn't want the patient to know even their diagnosis or what we're going to do to them. And so those present ethical challenges. But I'm sure all the providers in this room have come across that situation. And everything really has to be individualized.
Yeah, I just want to make a comment. Having gone through 3 separate cancer experiences, not ever do I recall doctors or the treatment staff mentioning the psychological well-being of the patient. I've gone through the aftermath of the treatment where the patient obviously has many psychological issues in the treatment, the side effects, and the ongoing treatment. So I commend you for bringing this issue up because it's real. Thank you.
Thank you.
And I think to that, so personally as I was going through treatment, and every week, if many of you in this room are probably familiar with the distress thermometer tool, every week I got that thermometer to fill out, and every week I would circle 0 just because I was my radiation oncologist said I was very stoic. I kind of held a lot in, and at the end of treatment, or a few weeks after, he asked how I was doing, and I was like, I'm fine, which of course is the opposite of what I said here of tell your providers how you're doing. But, and it really just showed how much he knew me as a person, as a patient, that he was like, I'm going to send you to our psychologist. And without, I was very thankful for that, but I didn't tell him that. He got that information from reading me, my vibe or my aura, is that what they say now? So so even with some of those tools out there, like you have to be able to like zoom out and like see your patient too.
Just to piggyback on Julia's comment, I think there's a very large underreporting of distress, mental health, depression, anxiety. And again, we don't know what we aren't told, but as clinicians, I think we are becoming more aware and reading the room, understanding when we meet with you at the beginning of your treatment journey, understanding those dynamics, and then seeing that evolve and picking up on some of those communication barriers, frustrations, body language, tone of voice. I mean, there are many, many things that are non-communicated that we should be paying attention to. So I'm very hopeful that that's happening more and more. There's a lot more research and education and awareness about the need for mental health within this, as I think we've learned after treatment sometimes is the hardest. During, you're in
go mode, and it's when everything is done and the visits have stretched out that you may feel lost and unsupported, and that's maybe the time we need it the most to be there for you.
And I agree, and I think also to say that caregivers can sometimes get lost in the process. There's not a lot of resources oftentimes, I feel like, for caregivers, and their stress and their psychological well-being can really take a toll as they support someone through this process. And so if you are a caregiver, it is so important for you to take care of yourself, including, both your physical but also your mental health. And so it is okay as a caregiver to take a break sometimes and take care of yourself. And I agree that I often see it's really when the treatment ends and you're waiting and you've put so much time and energy into getting through that treatment, it then becomes, what do I do now? And I think that's where psychological support is really helpful.
And just one more response to that comment. I feel like all of us spend, 10 to 15 years of our lives studying to be specialized in one thing. And for me, it's doing surgery and doing reconstructive surgery and cancer surgery. And we don't spend time learning about the psychological and the mental and the physical or the emotional impact on patients. And so that's on-the-job learning. And some of us are better at it than others. But I do think one thing that I've seen in going to these meetings is anyone who takes care of head and neck cancer, I feel like it's a special group of people because there's been so much on-the-job learning about the psychological, mental, and emotional impact to patients because it's such a critical part of how everyone feels who they are.
I just wanted to mention that one discipline that hasn't been brought up yet, everybody who's gone through cancer treatment appreciates how many people are involved in your care, and I understand that's extremely overwhelming at times. But one discipline that's fairly new to the cancer care team is a navigator. Some navigators are non-clinical, but some are clinical. I work as a clinical navigator, and one of the things, the primary role of a clinical or even non-clinical navigator is to address barriers to care and to connect patients to resources. So, if you've already gone through cancer treatment and it's been a few years, you may or may not have had a navigator on your team, but if you're still in active treatment or in the, early survivorship, I would say reach out to your care team and see if you have a navigator on your team, because that person is an advocate between your needs and the medical system. So I just wanted to bring some awareness to that person's role as well. And most cancer centers now have some type of navigator available to patients.
All right, and I think with that, we are at time. We have one more.
I was just going to say that was a perfect segue. I'm the patient resource navigator for the Alliance. So if you don't have a navigator or you are looking for a navigator associated with your setting, please reach out to me as well. I'm very happy to connect you to those resources or find the answer if I don't know it right away. But I did want to mention some of our support that we do offer to anyone who, if you are not familiar with some of our programs, we have quite a few programs that can help you with some of the psychological support as well as some of the interpersonal support. So we do have a peer-to-peer program where if you would like to connect with somebody with a similar diagnosis as yours, or if you're a caregiver, we can connect you with a peer to speak with them no matter what your communication style. Or if you would like to be a mentor, we can help you connect with that. And we partner with Immerman Angels for that. And our other online support group is through Inspire. And I kind of describe it like social media for head and neck cancer survivors and patients and caregivers. And we have a policy that no post goes unanswered. So we have a lot of our ambassadors who are also wonderful people to connect with, that we can give you some of that connection that you may be seeking. So please reach out. Please remember, everything's on our website, but I'm here today personally. You can reach out to me as well. My name again is Melissa Cook, or any of our other staff members. We're happy to help.
All right, I think that wraps up the panel. Thank you to our panelists, Dr. Megami, Dr. Kaltman, Julia, and Beverly, and I think it's time for lunch.